Okay, I'm on a small laptop, so if you've got a question or if there's a recording that we're not doing, just can you just yell out? Okay. So there's the safety guidelines. So I recommend you read those. I also recommend you read your ISAP from last year. Okay, so that's important for this year because it talks about antenna effect and radio frequency, and you would have done a lot of investigation into that. Hopefully, most of you did. So you need to read that ISAP and just refresh your mind about what those what that was all about and those principles involved in that ISAP. Okay. The part A, the questions that I've been reading out, they are they'll be short answer questions. Okay, so part A is all about short answer questions. Any questions so far on part A? No? All right, I assume everyone's still here. I've got this terrible feeling that I just launch into stuff and I'm talking to myself. Okay, so cerebral imaging principles are worth 10 marks. All right, so that's the basic principles. A lot of that was covered last year. That's the basic principles about scanning the brain. Okay, so maybe the different sequences, what are the B values we use? What coils do we use? What's the difference between a T1 MP range and a spin echo sequence or a turbo spin echo T1 sequence? I remember there was a slide on, or do you remember there was a slide on the MP range, and that's the sequence that we like to use to show contrast between the grey and the white matter. So little bits and bobs like that. The difference of T2 appearance on spin echo and fast spin echo imaging. We had a slide there, so you need to look through those slides and just identify the points that I made, the reason for those slides and the points that I made on those slides. So that's worth 10 marks. That's cerebral imaging principles worth 10 marks. And then there's cerebral imaging pathology worth 16 marks. So that looks at the different protocols. Okay, so what are the main sort of sequences we would do for a stroke brain, for the common protocols? And we know protocols are a group of sequences. We can divvy it down. So we know we have parameters. Okay, we'll start from the bottom. So we have parameters like the TR, the TE, the flip angle, and they're all those parameters make up a sequence. Okay, so we have a sequence that's made, and the sequence might be a T1 spin echo sagittal of the brain. That's made up of the different parameters. So the parameters will be TR is 600, TE might be 15, flip angle, da, 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 da. Okay, so they're the parameters. They make up the sequence. The protocol, so a stroke brain, a tumor brain, is made up by different sequences. Okay. So if I asked you for a protocol of a patient, what protocol would you use on a patient who is suffering from a astrocytoma? Then the correct answer would be a tumor brain. Okay, so we do a tumor brain that has a T1 sagittal, it has a T2 axial, it has a T2 flare, it has a T1 axial, it would have a DWI to see the any infarct and to identify the type of tumor or help identify the type of tumor, and it would have a SWE, okay, to see if the tumor is bleeding. And then after that, we would give contrast. The most important part of this protocol is to give contrast and identify the vascularity of that tumour. Okay, so that's the type of things. We have the parameters, the sequences, the protocols, and then of course we just have an examination, which is the MRI. Okay. So that's the second part of the brain. And we have to, so that's going to be looking at the different structure, the different protocols, and the different types of, or the different parameters in those protocols that we've discussed. Okay, so an example might be a DWI. We've discussed the B values, and maybe long TR and long TE for T2 weighting, things like that. Okay.
Richard, I had a question relating to the brain. In the multiple sclerosis protocol, there's sequences for the posterior fossa. I was just wondering why we do sequences for the posterior fossa. Is it because we can have plaques in the cerebellum as well?
Not often. Excellent question. Good one. Not often. The reason we have high resolution images through the cerebellum is because the symptoms of MS are very close to the symptoms that you'd get if you had pathology in the cerebellum. Excellent question. So
okay, thank you very much.
Yeah. To be honest, I don't think there's many plaques. I haven't seen many plaques in the cerebellum. I guess it's possible, but certainly in the brainstem there is. It's possible, but the reason for doing those scans, high resolution scans through the cerebellum, is to identify any pathology in the cerebellum that may mimic the symptoms of MS. You get slow, responsive. In coordination with MS, it would be difficult to coordinate movements, and that would be exactly the same symptoms as the cerebellum. Good question. Excellent.
And is that routinely performed across all sites? Because from memory, I don't remember it being done at my site. We only just did a cube sagittal flare.
I don't think anything is routinely performed across all sites. I think because it's up to the radiologist. The radiologists have got all those options. I know we've had, even at our site, I've worked here under 4 different radiologists who have looked after MRI, and they've each favoured different sequences. So every time we get a new radiologist that looks after MRI, we seem to get a new set of sequences for things. So and that's why I leave it up to you guys. I don't like all the sequences that I've given you are suggestions, and I've given you reasons why we do those sequences. It's really difficult. MR is really difficult because we have so many options. I guess in a way you could take it back, and it's like treating a patient, or doing anything diagnostic on a patient. They have pathology. What do you do? Do you do an MRI? Do you do a biopsy? Do you do a spinal tap? Do you do a CT? Can you do an X-ray, an ultrasound? It's really up to the referring clinician as to what tests they send someone. I mean, there's recommended tests, but referring clinicians like different tests. Exactly the same as radiologists. They like different sequences. So it's very hard for me to tell you this sequence or that sequence is done across multiple sites, unfortunately. And that, I know that makes it hard for learning. So so I've got to be lenient in in your answers. So if you did a set of sequences at clinic for MS, then if you write those down and you explain why, I can't mark them wrong, you know. the one sequence that you mentioned there was sagittal flare, and that's probably that is the main sequence. That it's the that's the sequence that you really couldn't do without in MS. Okay, and a radiologist, if a radiologist didn't want a sagittal flare in MS, then that scanner would be deficient. Yeah.
Okay.
So yeah, it's really hard for me to say definitely do this, and this. So yeah.
Richard, could I
Yeah.
just confirm? So the cerebral imaging, is that still part of part A of the exam?
Yep. So part A is made up of safety that I mentioned. It's made up of 10 marks on basic cerebral imaging, and I think it's 15 marks on protocols and imaging pathology. So 16 marks. So part A is made up of the safety that I went through, 10 marks on cerebral imaging, and 16 marks on cerebral imaging pathology. So by that, I mean, what sequences would you use to image a patient who's suffering a tumor brain? What and why? What would there be? Maybe a stroke. What would be the appearance of a stroke, of a hemorrhagic stroke, on a SWE image? And what else could I say? I think I've got a question on metastases. So make sure you know the type of information that MR offers a patient with metastases. And do you remember that with metastases, it's a brain pathology, but the cells that have caused that pathology have come from other areas in the body. So you might have very rare, but you might have a prostate metastases in the brain. More common, you might have breast metastases. So they're actually prostate or breast cells that have traveled up to the brain. So they're going to have different appearances because they're different types of cells. Okay, so things like that. I think I just went off a complete tangent, but did I answer your question then, Carla? Was it Carla?
Yep, it was me. And yes, thank you.
Good. Okay. Okay, so that's part A. Anyone still unclear about what's in part A on the test? It's pretty much everything that I've mentioned based on the PowerPoints, the Moodle books, and yeah, that's probably about it. The Moodle books, the PowerPoints. What else have I presented in the lecture? Make sure you look at your safety stuff, your PowerPoints and things that we covered in the first lecture, and make sure you have, you look at your ISAP from last year, and make sure you look at that website that I've just posted up here. Okay, it's not long. Of course, I find it interesting that I would, but print it out, highlight it, read through it, just so as you get an understanding. Right. Okay. So that's part A. Part B. The other thing too is it's not a tricky exam. It's not something, please don't go home and panic or worry about it. It's not a tricky exam. It's a fairly basic exam that just covers what I've discussed this semester. So if you've been... Yeah.
Can I ask a question? This might sound very silly.
No, nothing silly.
Oh, no, it's more just advice about how to approach studying. So currently my notes are 137 pages long. It's all of your content from like your PowerPoints and the Moodle books. How do you recommend like going through it and not going crazy? Because I'm a bit worried.
Don't be worried. Don't be worried. If you've done 137 pages of notes, then
I haven't retained, let's just clarify, I haven't retained most of it because I'm a bit slow, but yeah, how do you recommend going about it?
I would 137 pages of notes.
I can like share and like scroll through it if you want to see.
Are they? Is that just from my lectures?
Can you see my screen?
I can't. Hang on.
It says I'm sharing.
Okay, I'll just. Oh yeah.
Yeah, so like in the corner, 139, and it's like it's got pictures, but just a lot of text. So
Yeah.
just like I wanted to hear like how you recommend to go about it.
Yeah. I think just read it. I suppose we've had nearly 4 or 5 months of lectures, and I'm hoping that you've grasped most of it, because everyone in the past has grasped most of it, or all of it, from what I'm aware of, and everyone's done really well in their end of year exam. So hopefully you can read through those. You can understand 137 pages and understand and memorize 137 pages of notes, because it is a semester. It has been a semester subject, and that's been the content.
Yeah, fair enough. Thanks, Richard. Just wanted to ask. And
yeah, no, that's fair enough. I understand, and it does sound a lot, but you know, I'm hoping that in the past no one's had a problem. You don't have to stress. You just read your notes and understand the content, which is a stupid answer, but you know, everything that I examine will be on your notes. So yeah, like any other subject, I'm guessing.
no worries. Thanks, Richard. I appreciate it.
No, that's okay. That's okay.
Richard, I have another question, sorry.
No, go
So
for
you
it.
know how you said that you could ask us like the difference of T2 appearances like with different acquisition types? Would you do that through like images? So like would we be expected to like be able to label, I don't know, pathology or like the weighting of an image or anatomy in the exam?
We've got a part on the exam. On part C is on is multiple choice and matching, and a couple of false questions, and that's on anatomy and pathology. And I will get to that. Yeah. So so there's definitely anatomy and pathology on.
Okay.
Yeah.
Thank you.
Thank you. Okay. So maybe we'll just get to go to part B, and we'll have a look at that. So what have we got? So we've got part B. So part A is on safety and brain. Part B is on, we've got 14 marks on the spine. Okay, so the spine, make sure you know the difference between myelopathy and radiculopathy. Insofar as what causes or what causes pain or lesions or whatever. The imaging that we choose. So we know radiculopathy, we need fine slices to see those nerve roots, and we need quite high contrast to see those nerve roots out from the CSF, whereas in the spine, in the lesions or the myelopathy, we need high signal to see the lesions within the cord. Okay, they're the main things. Certainly with radiculopathy as well, you need both. So we know that there can be a compression on the cord from the spine, or from the disc can compress on the cord. So we need to see fine slices through that area to see the compression of that disc on the nerves and on the nerves coming out of the cord. We also need to see thick slices, thicker, high signal intensity slices through the cord to see if that disc bulge that's pressed on that nerve on the cord has caused any damage in the cord. Okay. Whereas in myelopathy, we just have to see the damage on the cord, because caused by maybe an MS lesion is that typical myelopathic lesion, maybe a tumor, maybe something else inside the actual cord rather than extrinsic compression. Okay. Also, what else did we discuss with our spine? We discussed post-operative spine, so we give contrast. We have to know, or to differentiate, we give the contrast to differentiate scar tissue from recurrent disc. And we know that's important because recurrent disc, the patient will likely need another operation, whereas scar tissue won't benefit, the patient won't benefit from another operation. Okay. We know that if we're looking at myelopathic lesions in the cord, there's no need to do lumbar spine, okay, because there's no cord in the lumbar spine. There's only cord in the cervical and the thoracic spine, okay, and then it breaks into cauda equina in the lumbar spine. Okay, so we have to remember that. We remember that we have conus. It is about T12 to L1, so we must scan down to at least the conus if we're looking for myelopathy. Basic, as I say with the spine, you have basic, you know the basic sequences. So we do T1, we do sagittal scans of the spine, we do axial scans for the axial, maybe gradient scans for the myelopathic lesions, and we do fine slices through the spine for radiculopathy lesions. If there's any contrast in any of the spine or any of the, if there's any tumours or infections in any of the spine or any of the brain or any of the body, then we always need to give contrast, okay, unless there's a contraindication. We know that if there's tumours or infection, they're vascular, and so we have to give contrast, okay. What else do we have to know? I think we did some infection. I'm trying to think of the spine imaging. We did some infection with a big lesion. Was there anything else that we did in the spine that you want to point out? No. Okay. Possibly scoliosis. So if we've got a scoliotic patient, then we try and do coronals as well. Okay, and obviously doing coronals through the spine will show the lateral deviation of the spine. However, sagittals are more routine. Okay, sagittals and axials through the spine. Then we talked about, so that's worth 14 marks of the spine. Then we talked about chest abdo-pelvis, and that's worth 10 marks. Okay, so we talked about the heart and the type of projections that we do through the heart and the basic structures that we see. So The 4-chamber, we see the 2 valves, we see the 4 chambers. The 2-chamber, we say the left 2-chamber, we see the atrium, the ventricle, and the mitral valve. And the right 2-chamber, atrial, ventricle, and the tricuspid valve. Outflow tract, we see the atrium, the ventricle, and the aortic root as that blood flows into the ventricle and out through the ascending aorta. What else do we do with the heart? I think that was the main thing. The myocardium we know is quite thick. And the short axis view through the heart. We have what else? We have the different images of the different structures in the abdomen, the importance of gating and respiration in the abdomen. Also we have, but basically most of the structures that we discussed in pretty much everything was we want T1s, we want T2s, MSK is generally with fat sat, abdomen not so much fat sat, although if you put fat sat in, I'm certainly not going to mark you wrong. So T1s, T2s plus or minus fat sat, and then we're going to have contrast. And a lot of the structures in the abdomen, we want dynamic scans. Okay, so we see the blood going in into those structures. And then we remember that the dynamic scans through the breast. The lesions, if the lesion is malignant, it uptakes the contrast time curve is very steep. So the contrast goes into those malignant structures fast. Whereas if the structure is not so malignant, if it's benign, which is not so malignant, then it goes in very slow or relatively slower than the malignant structures. Okay, and that's pretty much everything in the body, but we discussed that in relation to the breast, okay, and the malignant and the benign lesions in the breast. Okay, so the breast, we might do a T1, we would do a T2 with fat sat to show the fluid as pathology. So T1 for anatomy, T2 for pathology, and then we give contrast and we do the fast uptake scans to see the vascularity of these structures, or these pathology rather, and then we might do maybe 3 or 4 minute scans to get more detail or more high resolution, high signal T1s with the contrast. Okay, we talked about silicone breast implants, and there was a couple of pathologies that we did with the silicone breast. And we know that we saturate, if you've got fat, water and silicone, we always saturate the fat and the water, okay? Because we're looking for the silicone outside of the capsule. We remember that if we don't have, if we saturate the silicone, then we're not going to see it outside the capsule, which defeats the purpose of the test, okay? We went down, in and out of phase imaging of the liver. So we discussed that as being able, in and out of phase imaging of anything is able to tell the difference between fat and water. Okay, and they use in and out of phase imaging. You might have heard of Dixon, or you will have heard of Dixon imaging, which is using in and out of phase imaging to create fat and water saturation. Okay, we see the behavior of a substance in phase, we see a behavior of the substance out of phase, and then we compare those substances, or the machine compares those substances and decides what in that area or in that anatomy is fat and what in that anatomy is water. Okay. So that's a big part of liver imaging. It's a big part. It can be a big part of abdo imaging. Moving down to the pelvis, the rectum, and the cervix, we discussed about the importance of keeping them absolutely perpendicular to those structures, okay, because we want to tell the difference. We want to see we want to be able to, or the doctors want to be able to stage the tumour. Okay, so they'll be able to see whether the tumour is inside or outside the cervix or the rectum, okay, or if it's invaded the wall of the cervix or the rectum. Okay, do you remember, you don't need to know the different stages, but just know that there are 4 stages. And to stage a tumour, it is very important to go perpendicular to those structures. Okay, if you go oblique, you're not going to be able to identify how much of the tumour has gone in through the structure and whether it's gone in or whether it's gone outside. It's invaded outside regions as well. Okay. The shoulder, how do we position the shoulder? We position the shoulder along the supraspinatus tendon. We discussed the labrum. We discussed and how recurrent dislocation. So if we've got a labral tear, then the patient has or may have recurrent dislocations. The same as if they dislocate their shoulder, then they can lax a lot of their ligaments. A lot of their ligaments can stretch and they can have recurrent dislocations. We talked about intra-articular contrast for the shoulder and how that shows up a labral tear because the contrast seeps into the labrum. We also talked about intra-articular contrast going into the rotator cuff muscles and ligaments, rotator cuff tendon, sorry. So if there's a tear on the articular side, then the contrast will go into that tear. Whereas if there's a tear on the bursa side, then the contrast won't go into that tear. Okay, so you're not necessarily going to see a rotator cuff tear doing an intra-articular contrast injection because the contrast won't get to that tear if it's on the bursa side. We talked about, what else did we talk about? What else did we talk about on the shoulder? Maybe acute injuries of the shoulder. So tears. If you have a torn supraspinatus tendon, then that's going to be hyper intense on the T2 fat sat. Okay, because like any other pathology, it's going to have edema around it. Okay, it's going to be hypo-intense on the T1 image or the proton density image because that's more of an anatomy sequence. So you may see the actual tear on that sequence. However, that we know the T2 is going to have signal in it from edema, okay, an acute tear. And then we saw an image with the when it had atrophied, how the fat had replaced that tear. Okay, so the muscle had gone into, had wasted away, so it had atrophied, but the body decided to store fat in that muscle as well. Okay. So the shoulder is 7 marks. Then we got onto the knee, that's 8 marks. We talked about the main thing about knee was the different we talked about the different sequences. So we could do proton density or T1, and we could do T2 FATSAT or proton density FATSAT, okay, in the 3 different planes. We know we angle the axial scan along the ACL in order to get that nice ACL image, in the ACL in one image, or possibly 2 images, rather than cut it along portions. Same thing applies with the knee, in that if you get an acute pathology, it becomes hyperintense. We looked at the different structures in the knee, and we evaluated whether they were hyperintense, which the ligaments, tendons mostly are, because they're made up of collagen and they have very little hydrogen protons. The meniscus, we talked about meniscal tears, where we had bright signal within the meniscus. We talked about the cartilage, how it has different layers, 3 or 4 different layers, and damaged cartilage. You can see on the T1 by the disruption to those layers, and the T2 FATSAT or the proton density FATSAT by the increased fluid around those tears or that damage. Okay, so that's the knee. MRI PET. So we basically we've talked very basically about the information we gained from PET imaging. We know that PET imaging or nuclear medicine is a lot of functional imaging. Okay, so it's we look at it as we look at it towards information, gaining information about the metabolic activity or functional information about the different processes in the body, physiological processes in the body, rather than anatomical or pathological structural information like we get in MRI. Okay, so because we don't get that information, we need CT or we need MRI to give us that information. So we have to superimpose that information on PET scans. Okay, we talked about, so we never do PET alone. We always do PET with anatomical imaging. We talked about how we need attenuation correction because we can't change the intensity of the X-ray. So we know they come out at 511 kiloelectron volts, and not on a chest X-ray, when it goes through lungs, we can dial down the energy or play with the KV, MAS, whatever. But with PET imaging, we can't do that. We need to determine how much tissue that signal goes through in order to get to the detectors. We need an attenuation and magnetic resonance attenuation correction algorithm or image that lends itself to an algorithm so as that this attenuation can be calculated, and so you can compare like structures with like structures. You can also get quantitative information after an attenuation corrected image. Okay, whereas you can't get quantitative information if the image hasn't been attenuated, corrected, whatever, because you're going to have to take into account the attenuation in the body. Okay, and basically the information from an unattenuated corrected image is useless. We thought we had a slide there to identify the different types of attenuation correction methods, and we had 2 images there that showed you the difference. Okay, so be able to identify those images, be able to identify the difference between attenuated and unattenuated corrected images. We also talked about the different structures in the room, or the different features of a room, of an MR room that needed, that was converted to a PET room. So it needs to be shielded because we're dealing with radioactivity that we're not dealing with when we just have MR. You need to have devices in there that are capable of giving radiation to the patient, and they need to be MR compatible. Okay, so they need to be shielded and they need to be MR compatible. The room still has to be MR compatible, so we know we need copper in the walls, and a certain thickness of lead for the PET. Okay, so the purpose of the copper Faraday cage is to stop radio frequency getting into the room. Not necessarily, we don't care about the radio frequency emitted from the room. It's radio frequency getting into the room. What else did we do? What else did we talk about? We talked about the setup of the room. I can't remember really what else we talked about with the PET imaging. And then advanced imaging, advanced techniques. We talked about functional imaging, and how the bold principle. So as we do a task, maybe finger tapping, we use that as an example. We did finger tapping. The more you tap the fingers, not only does the muscles in the arm increase in their use of oxygen, but also the muscle, the cells in the brain increase their uptake of oxygen. So, and we know that the more oxygen in the brain, the less, the more it's shielded. Okay, so that means the higher the signal. All right, so if an area in the brain has more oxygen, then the oxygen is going to shield that ion, and it's going to decrease the magnetic susceptibility, which will increase the signal. All right, that's going to be 10 marks for advanced techniques. We also talked about high field strength. What's the main benefit of high field strength? What benefit does that offer an image? And that's signal to noise. Okay, so we still might have the same parameters. So the pixel size will be the same. We can do the same, if we use the same parameters, then the scan time is exactly the same. We just get a lot more signal. If we get a lot more signal, maybe then we can use parameters, change the parameters. We can maybe halve the nets, or we can increase the resolution and get the same amount of signal in our images. Okay, so the main thing with that is high signal. What's the principle behind diffusion? We know that water travels along a white matter tract, and so you get an increase in diffusivity along that length of the white matter tract, okay, because water will be effectively in the same plane, okay. As soon as you change the plane of that B value or the gradient, then the water in another white matter tract won't flow in that direction, so you won't get a signal back when you're imaging in that direction. Okay, so the more directions you do, the more information you're going to get back, or the more directional information you're going to get back about that white matter tract. And the stronger the gradient, the more specific information of that in that. We know MRS is spectroscopy. So each metabolite, because of electron shielding, each metabolite resonates at a different frequency. Okay, so if that's the case, we know that we can work out the frequencies that they resonate in, or we know what frequencies they resonate in. So we can work out, okay, if this metabolite resonates at a certain frequency, then we know that that metabolite is, we know what that metabolite is. Okay, and so we work out, or the machine works out, the area under that curve. We have to, there might be something else I went home and I thought I didn't spell out in that lecture, so I might do that after the break. We talked about parts per million, and we worked out that that was a standardized measure, that so we can compare the different Tesla machines. Okay, so its basis is in hertz. So we know we have a signal on one side and we have a hertz on the bottom, okay, of that graph. So the different metabolites are different frequencies, so they have different hertz, which we transform into parts per million so we can compare them. Okay. And then the higher the peak, the more signal we have. And we also talked about ASL, so arterial spin labeling, how we can do perfusion imaging without needing contrast. We tag the spins at the neck, and then once those cells in the blood vessels travel to the brain, we can work out how fast they travel to the different parts of the brain, and we can work out the signal. Okay, and that gives us information about the different perfusion within the brain. Okay, so advanced techniques I was just talking about is 10 marks. MRI PET imaging is 6 marks. Knee is 8 marks. Shoulder is 7 marks. Chest
Did his laptop die or something?
So I'll just continue. Knee is 22 marks.
Very deep voice, Adele.
Yep.
Oh,
Elvis.
did I just drop out?
Yeah, you dropped out.
Hello? Oh, for how long?
Oh, just like a minute.
Yeah, I think you just said cap is
Oh,
chest abdo-pelvis is 10 marks, I think was the last thing you said.
okay. Did you get the ASL?
Yeah.
We talked about the ASL.
Yeah, we got that bit. And then you started going through which section is worth however many marks, and then you dropped out as you were giving the marks for each section.
Right. Okay. I'll do that again, and I'll just go off my phone. I'll hotspot off my phone. Okay. All right. Let's have a look. Where was I? Yeah. It's okay. It's just students. Just students. Okay, so MRI of the spine is 14 marks. Chest abdo pelvis is 10 marks. Shoulder is 7 marks. Knee is 8 marks. MRI PET imaging is 6 marks. Advanced technique is 10 marks. How's that? Everyone get that okay for part B? And they're all written answers. So part A and part B are all written.
Richard, I just had a question.
Right.
You spoke about proton density in T1 and proton density FATSAT and T2 FATSAT. When would you choose to do one or the other, or what are the benefits of each?
Yeah, good question. It's more, proton density is, let's say we're going to keep it simple. You can do it in the rest of the body, but it's not, we reserve it mainly for MSK. Okay, so spine does have a few proton density applications. I think I've got one slide that shows you myelopathy with proton density. Other than that, I'm trying to think. I can't think. Very rarely do it in the brain because we just don't get the contrast. It's the proton density of images in the brain are fairly grey. So I think it's safe to say it's reserved for MSK. With MSK, if we do proton density of a knee or a shoulder, we don't need to, and on the generally speaking, and again, there's radiologists who would probably come in and bash me in the face if I said this, but there's other radiologists who would support it. So generally speaking, we don't need proton density imaging if we're doing T1 imaging, okay? And we don't need T1 imaging if we've got proton density imaging. All right, so if you have a look, there was a slide in on the foot in the knee section, and it had two proton density images set side by side. And if you can remember, the only difference was that proton density of the fluid was bright, but as a whole, the images showed really good anatomy, okay? Whereas proton density FATSAT is very similar to T2 FATSAT. Okay, so again, fluid is bright, and so T2 we know fluid is bright. So if you had a proton density FATSAT image, you wouldn't necessarily need I don't think there's much point in having a T2 FATSAT image if you had a proton density FATSAT image. Okay. They're both pathology weighted, so they both show pathological different pathology in the area that you're scanning. So if I was the main thing if I ask you on sequences for the knee or the shoulder, or even the knee or the shoulder, the main thing I'm looking for is that you either give me proton density and proton density, you either give me maybe 2, maybe 3 planes of proton density or T1 weighted, and 2 or 3 planes of T2 FATSAT or proton density FATSAT images. Okay, don't give me I will mark you wrong if you give me proton density and 2 or 3 planes of proton density and 2 or 3 planes of T1 weighted images, or a protocol where you give me proton density FATSAT in 2 or 3 planes and PD FATSAT in 2 or 3 planes, because essentially those 2 sets of sequences show the same thing. They're both pathology weighted in the T2 FATSAT proton density FATSAT sequences. Okay, does that make sense to you guys? Is that?
Yeah, that makes sense.
That makes sense. Having said that, we also talked about tumor and infection protocol. So what I've really just talked about is mechanical damage, or we call it derangement. Okay, so we do a shoulder or a knee as a derangement protocol, which basically means looking at the ligaments, at the tendons, cartilage, synovial fluid, structures around the joints. Okay, remember that when we're doing imaging for T1 and T2 if we're doing imaging for infection or tumor in the MSK, then we really need T1s and T2 FATSATs. Okay, there's a bit more contrast, and the main and if you gave me proton density fat sats for tumor, I would still mark you right and proton density, as long as you had some T1, at least 1 or 2 T1s before GAD. Okay, and the reason for that is if you do proton densities before GAD, where water fluid structures may be bright, and then you do T1 after GAD, you don't know whether the structures before GAD were bright because they were fluid, were bright because they were inflammation with fluid, or were bright because of fat. Okay, so you don't know if they were bright after contrast. Then you have little idea about what they would have looked like on a T1 weighted image before contrast. So it still leaves a question as to what they are, okay? Because if something was enhanced after contrast, but it wasn't enhanced before contrast, then there's a good chance that contrast, well, there's nothing else. Contrast has obviously contributed to that structure being enhanced. Okay, so it's an enhanced structure. It's a vascular structure, and if it's pathology and it's vascular, then it's inflammation, tumor, infection, sort of a pathology. Okay. Remember, we also give we also do fat sat pulses after contrast, because when we do a scan and we give contrast, we want to null the signal from fat. Okay, fat's bright on T1. If we null the signal from fat, then the only thing that's bright is contrast and possibly blood. Okay, depending on what age it is, what stage it's at. And if it's blood, we know that we would have seen it pre-GAD if we'd done T1 contrast. Okay, so we can identify blood post-contrast. But if we did a proton density weighted image before contrast and then gave GAD and something enhanced after contrast, we don't know what that structure would have done without contrast. So we can't rule anything out. Okay. I'm really sorry, but again, I've forgotten the question.
No, it's all answered. Thank you.
Okay. All right. What about we have a rest? What about we have 8 minutes of rest? I'm going to stay here. If there's anything that you guys, and I'm going to stop recording. Damn, can everyone still hear me?
Yeah, all good.
Good. Okay. Yeah, no one told, I've paused recording. So, yeah, I knew I'd do that. So I'll go back, because I paused revision, I paused recording. I'll go back and just say, the weightings, there's nothing brain busting. It's 15 marks for parameters, trade-offs and artifacts. I think it was 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 16, 17, 18, 22, 26 marks for anatomy, and I think it was 19 marks for pathology. Okay, so anatomy, the structures might be a little bit different to what's been on your slides, the presentation of the structures, but the structures that are on your slide are only the structures that we're going to test. I'm not going to test anything else. You won't find anything else on the test. Okay, and as I say, there's nothing brain busting there. There's nothing that's real. It's just a test of what you understand and make sure you've been paying attention and you've understand the certainly the basic content that I've discussed this semester. Okay, so we've got half an hour left. Can't believe I've managed to talk for an hour and a half. Is there anything? I'm gonna go through, I'll present you with this. This Word document is on your Moodle site in this week, and it's an example of questions that we're going to cover on the test. Okay. So if you can sit here and go through all those questions and understand them and get on these questions, then you'll get 100% on the test. Is there anything here that anyone wants to go through? Have a read through it and yell out if there's something that you're not sure of that you want me to talk about. Or just chat me and privately chat me if you're too embarrassed like I would have been. And I'm very happy to go through it.
Hey, Richard.
Yeah.
Hey, just a question about the pulse oximeter into the room. Is that safe? Because I don't see why it wouldn't be safe. Like, I think it's just mainly plastic. I'm not sure if there's any other metal components within it.
Okay. Okay. So, the pulse oximeter it's a mechanical device. So you can't bring the actual device in. So it would be exactly the same as bringing in anything else. My laptop, a keyboard, I don't know, the microphone. It's a mechanical device. So, and it's the actual pulsimeter machine isn't designed or might not be designed to go inside the MR room. Okay. If it is designed and it has a sticker and you know that it's designed to go in the MRI room, then yes, you would be able to bring it in. Okay. What we usually have is we have a pulse oximeter that stays out of the room, the device that stays out of the room, and a optical fiber lead going into the room. And we know that optical fiber isn't metallic, so it isn't a problem if that goes in the room. And the actual display unit is outside of the room. Okay. In answering that question, you don't need to go. I don't need you to know whether a pulse oximeter is safe or it's not safe. Basically, all you would say there is if it's safe, if it's built to go in the MRI room, it can go in the MRI room as long as it doesn't exceed the spatial gradient that it's built to, or the conditions. It doesn't exceed the conditions that it's rated to, okay, which is the spatial gradient more often than not. So I'm not asking you about pulse oximeters that are MR compatible. I'm asking you about devices in general that you can't just bring them into the room. You can't just get a pulse oximeter from the ward or from the bench, take it into the room. Okay, unless it's MR compatible. Does that make sense?
Yep, that makes sense. Thank you.
Okay. Anyone else got anything on there that they might find tricky?
Richard, would you mind talking about the truncation artifact right down the bottom?
Yes, great. Okay, so truncation artifact is it's most prominent at borders. So what I might do is I might stop sharing, and I'm going to get a picture from the internet so I can see. To me, it's a little bit different than the PowerPoint, and it's so we can use something different. Okay, there's a good one. Moodle is pretty Zoom is pretty clever, isn't it? There we go. So I've just Googled truncation artifact, and this is a good one insofar as you can see the bright and dark bands of contrast, where this brain phantom, the substance inside the brain phantom, meets the air. It's caused by a difference in signal intensity or contrast between two structures. Okay, so at the high contrast areas, in the phase direction, the high contrast areas causes bands. And you can see here on the actual brain imaging, there we are. So you can see there on the actual brain imaging, you can see those bright and dark bands in the brain. Okay, caused by the difference in intensities between the material, the tissue in the brain, and the bone and the air. Okay, has caused those. So they're in the phase direction, and the remedy to that is to increase the number of phase encodings. Okay, because you know the phase encoding, the signals, there's a finite number of signals you can get from each pixel, and so but the signals that you get back, you don't need to know the physics behind it, basically, but the signal you get back is infinite. It's a wave. Okay, so but there's a finite number of samples you can take from that wave. So if you can increase the number of samples, a number of phases that you can take from that wave, then you will decrease this artifact. Okay, I don't think you certainly don't need to know any more information than that. So it's a phase artifact, and it's at the borders between high and between the different densities of structures. Okay. How's that? Does that answer your question?
Yeah, very good. Thank you.
Thank you. Okay, so let's have another look and see what we can show. Anyone else? Anything else that people want to talk about? We've got another 10 minutes, say.
Hey, yeah, Richard, I was just looking at the second last question. It's just talking about the different artifacts. Is ghosting artifact the same as motion artifact?
Yes.
Oh, cool.
Absolutely.
I was
so
confused.
Yep. So ghosting artifact. So motion artifact appears as ghosting. And I don't, that's a great question, because I don't refer to ghosting that much, because it is confusing. I think, to me, ghosting could really be anything. Ghosting to me is like an artifact in itself. It's just something that's not there. And sorry for anyone who believes in ghosts, but they're not there. So it is a motion artifact, yes. Yes, it's the same thing.
Awesome, thank you.
Thank you. Excellent.
Richard, just had a question relating to that. Is it possible to get ghosting artifact from the movement of like normal fluid, like CSF?
Totally. Yep. Not so much CSF because the movement of CSF is quite slow. So you can get ghosting. In principle, you can, but if you're talking about ghosting of normal fluid, I think of veins and particularly arteries. You know how you have those flow artifacts, and there's a couple of slides where those flow artifacts go in the phase direction. That would be the same thing. Yeah.
Okay, no problem.
Yeah, definitely. CSF, you would get it, but not to the extent of of other normal structures that are flowing fast. Yeah, great.
Thank you very much.
Thank you. Anything else? How are we at parameters and trade-offs? Would we be able to explain what factors affect resolution? Would we be able to explain what parameters do not affect resolution? Anyone want to yell out a parameter that doesn't affect resolution?
The TR.
Perfect. Someone else?
Number of excitations.
Perfect. Two more.
The bandwidth or the receive bandwidth.
The receive bandwidth, I wouldn't go for, probably because that affects the frequency encoding. So it would affect it may affect the resolution in the frequency direction. Someone else?
TE.
Yep. TE. And one more. Anyone? Starts with an F.
Flip it out. Yeah, you already typed now. Dang it.
Yeah. Okay, so the flip angle. Okay, things like that. They wouldn't affect the resolution. Remember the SNR, the signal to noise ratio. Remember the things that affect the signal to noise ratio. Remember the things that affect the resolution. The effect of resolution on SNR is sort of an open question. It depends on what causes the change in resolution. Okay, certainly if you increase the resolution, then you're going to decrease the SNR simply because you've got less pixels or less signal within each pixel. Okay, the field of view is exactly the same thing. And the bandwidth, if you remember, do you remember that graph that we drew of the bandwidth? How if you had a small bandwidth, and it's on page, I started it now. It's on Westbrook. What did I say it was? Chapter 9? No, not 9. 7. that graph that we drew, as soon as I think of bandwidth and signal to noise, I think of that graph. Oh no, that's fat saturation. Oh, come on, man. Don't mind me, I'll just sit down and read a book. It's chapter 7, protocol optimization. It was chapter 7. Oh, I'd have to sit down and find it. And if I did, oh, there it is. Okay, where am I? So do you remember that graph we did? So basically, if you reduce the resolution, if you reduce your bandwidth, then you're going to get more signal. Okay, if you increase your bandwidth, you're going to get less signal because in that signal is also going to be noise. Okay, so if you think about, if I ask you a question about bandwidth and signal, think about that diagram. Okay, can anyone think I'm having a special on bandwidth at the moment. Can anyone think of an increase, why you would, or what would be a decrease? No, what would be a disadvantage of decreasing the bandwidth? What artifact would be increased when you decrease the bandwidth? Anyone?
Chemical shift.
Perfect. Well done. Excellent. Excellent. Okay, so chemical shift, if you decrease the bandwidth, then you're decreasing the number of hertz per pixel. Okay, so if you've got a bandwidth of 1,000 and you decrease it to 500, you're halving the number of hertz per pixel. And if we know that there's 220 hertz between fat and water on a 1.5 Tesla scanner, so if you halve the number of pixel, if you halve the distance or the bandwidth in each pixel, then what you're doing is you're spreading that out further away, okay? And we know chemical shift is where fat and water have different frequencies. So you're going to separate the signal of fat and water. Perfect, well done, excellent. Okay, anything else?
Yeah, Richard, just going back to quenching.
Yeah.
One of the top questions is what may happen during a quench if the quench pipe is blocked. Does that just stop the helium gas from being released?
If the quench, the helium gas will be released no matter what. If we quench, if we press that big red button, the helium gas will be released, okay? We know that normally it goes up the quench pipe and out into the atmosphere. If that pipe is blocked, then that gas will go either into the building or into the room, most likely into the room, okay? And what will happen is, and we also know that helium expands at 700 times. So we know that there'll be a ginormous increase in pressure inside the room, okay? So you imagine you've got 1 litre of helium turns into 700 litres of helium gas. 1 litre of liquid helium turns into 700 litres of helium gas, okay? And you've got a lot more than 1 litre of helium, believe me, probably thousands. In fact, I should suss that out. So what you're going to do is if that quench pipe is blocked or that vent is blocked, then that liquid helium will likely go into the room and cause a massive increase in pressure, okay? You don't have, quite often you don't have, well, the door may go out, okay, in which case it will blow out the door. Or if the door goes in, you will have a vent somewhere, so that vent will blow out, okay, because of the pressure. And then you'll be able to go in and get your patient, if that's department protocol, if it's safe to do so. Just make sure that you go along the floor where there's more oxygen, okay, just like a fire. But it's smoky, it's very cold. You won't be able to see anything. It's certainly far from ideal. So that would happen, and that's why the engineers service every quench pipe every 6 months. Does that answer that? Okay.
Yeah, perfect. Thank you.
Thank you. All right. What else? We'll have 5 minutes, unless you guys want to talk about something.
Richard, what does PNS stand for?
Peripheral nerve stimulation. Okay. So, yep. So that's caused by, great. So that's caused by the change in the magnetic field gradients, the spatial localization gradients. The faster we know that when a body or a conductive material experiences a change in magnetic field, we know that it sets up a current, okay? Anything that experiences a change in magnetic field will set up a current. So when we're doing a scan and we know that we change the magnetic fields for spatial localization and the gradients do that, that sets up a current in the body, okay? And if it sets up a current in my arm, then we know that that's nervous tissue. That nervous tissue works on current and it may twitch. Patient may twitch. Okay, so the change in magnetic field causes peripheral nerve stimulation. Okay, or that twitching in the muscles, or pins and needles, or any sort of artificial stimulation of the nerves. Good one. Anyone know another way of something else that we use to image structures in the abdomen? Breath hold. Something else?
I forgot what they're called. It's the one where they monitor the position of the diaphragm.
Perfect.
I can't remember what exactly it's called.
Anyone help him out? No?
Is it called the navigator?
Yep, that's the navigator. And what is the navigator? What is it? What's the term for navigator and bellows. They both do the same sort of thing. What is that?
Respiratory gating.
Perfect. Perfect. Good one. Okay. Last chance. Well, it's not the last chance. You can email me at any time if you're not sure of something. But last chance for this tutorial. No. Okay, so I think we'll wrap that up. Oh, hang on, we've got a chat. Oh. Okay. So please let me know if you've got any questions, if there's something that you're not sure of for the test. Hopefully, I'm sure we've covered everything. Please, I'm sorry we didn't get to meet face to face because I do enjoy these sessions and talking to you guys face to face and having a bit more interaction than I have, but I guess that's life. Please let me know if you need any help, obviously before the test, but after the test, if there's anything that you want to bounce off me or if there's any MR related stuff, then, you know, whenever, certainly shoot me an email. I'd be very happy to discuss anything with you guys. I am quite passionate about this stuff. So if there's any chance for me to learn or you guys to learn or anything, then yeah, it's a good topic. I enjoy it, and hopefully you will too going forward in your careers. There'll be a lot of developments in your time, certainly a lot of things to learn. So I'm going to start crying now, so I better sign off before I get all teary. Okay, any other questions, please email me. Let me know if there's any problems. The test isn't hard. It's just basic principles of what we've discussed. I know there's a lot to get through, but, you know, hopefully you've got the notes there and you can study what you need to get through. I'm sure you can. Okay.
Thank you, Richard. Really appreciate it.
Yeah, Richard, you've been great.
Great. Thank you very much. That's lovely.
Thank you.
At any time, if you want to come and have a chat at MBI or send me an email or see some PET MR, whatever, very happy. You know that I'm very happy to talk. Okay, and take care, Zev. Take care, everyone. Take care.